Okay, guys, back again here. I'm going to try and keep these at like 30 minutes a piece. Sorry, sometimes when I get to talking, it's just like, but I want to make sure that you at least have another review or another crack at getting a chance to really digest this material. And I hope that this is useful for y'all. So we did the intro. We're going to piggyback off of that. Now we're going into exclusively muscle contraction for this PowerPoint. So I'll point along the way just in case, for 30 seconds ago you didn't remember. This is a quick review coming off the second PowerPoint here. So monopolar setup, you got the active electrode placed over the target area, and then a dispersive electrode placed away from the target area. And this is like iontophoresis, typically for wounds, ionto edema control, so like a high volt ionto kind of setup. Then you got bipolar, two active electrodes of approximately the same size over the target area. We're going to use this for muscle weakness, for our NMES spasms, and to increase range of motion. And then muscle strengthening is going to require at least one active electrode over the motor point. And if you remember, the motor points are those specific areas within the muscle that are most apt to provide and facilitate a quality contraction within that muscle. So it's the sweet spot, for lack of better words. So here we go, NMES. What do we use NMES for? The big thing is going to be strengthening or limitation of atrophy, right? So we're either trying to improve the muscular performance of the strength of the muscle, or we're trying to defend against atrophy or decay or lessening of that muscle body. Excuse me. We're also trying to increase muscular endurance. We may be trying to re-educate that muscle and wake it up and say, hey, remember, we're supposed to be at work, to give you more enhanced central nervous system feedback and motor learning. You can also improve function. We can do this specifically with timing and coordination. We're trying to not just activate the muscle, but we're trying to help it to remember how it's supposed to work when we're doing functional activities. So I can either do this, for example, with a stimulator device or some kind of orthotic like we do for a drop foot, right? You've got this thing that wraps around the foot. It's got electrical stimulators placed on the tibialis anterior. So when they come through the gait cycle and they're trying to lift the toe up as they swing through, or they enter the swing phase, the electrical stimulator kicks in, fires tib anterior, dorsiflexes the foot, and allows for toe clearance during the swing phase. Or if I have somebody that's trying to work on something functional, the example we use maybe a work-related thing, right? So they're lifting a box or moving something, and they need activation, whether it's core stability, extension, maybe like of a hamstring, who knows what it could be. We're going to stimulate that muscle group, and then I'm going to have that person go through that functional activity while I'm stimulating them to try and improve the quality of that functional activity. I can also decrease muscle spasm. So this is where we're going to start to add fatigability into the mix, right? I'm going to tweak my on-off time parameters in order to take a muscle that's constantly firing and try and overpower it with electrical stimulation or supplemental electrical stimulation, excuse me, and get it to relax by basically asking it to overload itself. Treat spasticity and contractures. Muscle pump for edema control. Again, this is different from the way you'd use like an IFC. With this, you're going to actually have a mild contraction. We're trying to contract the muscle and get it to pump the fluid out of the area, increasing range of motion. Override reflex inhibition. These ones have asterisks because there's not a whole lot of efficacy to back up those claims as of yet. So we've got the alternating current, right? This is our up and down. It's going to continuously change from positive to negative in the direction of the current flow. So this is biphasic, right? It moves between the two, positive to negative and back again. It can be symmetrical in terms of in the sense that each amplitude or wave height is the same going each direction, or it can be asymmetrical in terms of maybe I got one tall amplitude and then a short amplitude, or a sinusoidal shape, which is just sort of a alternating changing of the shape, which I'm not super worried about. But symmetrical biphasic or Russian is going to be used most often for your NMES. So that means that it's going between a positive and negative phase, so there's no polar effect here because they're balancing out. and that each wavelength, each amplitude of each wave is the same, right? So my positive wavelength is this high, and my negative wavelength is this high, and they're both of equal length. You can use other things, but for the most part, it's going to be straight up symmetrical biphasic. So know that. There's your Russian. This is a polyphasic current. So it's just this goes what would be called like variable muscle stem or biphasic, right? AKA symmetrical biphasic. So the wavelengths are the same going each direction. This one is just as tall as this one, and they alter back and forth. The thing with the waveform in NMES and Russian is they sort of boxed and packaged this proper delivery system for NMES at 2500 hertz, where you have 10 microsecond bursts on and then 10 microsecond bursts off, usually delivered at 50 bursts per second. So it's just a specific package parameter in terms of how many bursts you have per second and how long each burst lasts. So we can just say it's a specific regimen that has a very particular dialed in pulse width, right? Each pulse is going to be only so long, and how many pulses per second. So it's sort of like plug and play. We'll talk about that in a sec. So this is the waveform, right, for variable muscle stem. You kind of know how it's going to work in terms of modulation. Means that you're just controlling and influencing the meaning and the parameters of what you're doing. So you've got a biphasic waveform. Here's the positive, here's the negative. And you're going to manipulate or vary your phase durations, your pulse rate, your pulse interval, and using those variations in either phase duration, pulse rate, or the interval in between, or your on-off time. That's how we're going to achieve different things, and that's known as variable muscle stem. So here's your quad. We talked about this, the differences between the depth that you can achieve. Also remember that your smaller electrodes are providing a higher current density than your larger electrodes. So with this, for instance, here's a quad and here's a calf. These are placed a little bit, maybe even too close, right? But a little bit closer together, because to catch the gastroc, I'm not going to need to go super deep, and the muscle belly is not as substantial as it is with like a large quad. So I need to space those electrodes farther apart to penetrate more deeply in order to get the kind of quality contraction that I'm looking for NMES. Again, there it is. Smaller electrodes are going to produce a higher current density. So you got to separate them by at least the diameter of one active electrode. And wider separation minimizes superficial current. So as we also said, that when you place two electrodes too close together, the current stays very close to the surface. And if it's too close to the surface, you can actually burn someone, right? We're not achieving enough depth. In some cases, with your electrodes placed too close together, you're maybe from a very shallow perspective influencing muscular tissue, but that current is going to live more in the subcutaneous area. And the one thing we know is that you can't put too much heat or too much stimulus through that subcutaneous tissue, because you can burn people, right? It increases the specific heat. There's our motor control stuff, right? So this is pretty cool. This is an example of functional electrical stim like we talked about. If you've got a problem where you have some kind of impact on nerve control, like a SCI or stroke, multiple sclerosis, brain injury, whatever, CP, here's our stimulator. We've got where the toe hits down, or in this example, right, we've got a sort of a heel stimulator sensor on the bottom that says, hey, we're about to enter swing phase. Let's go ahead and fire up the stimulator to dorsiflex, or to fire tib anterior to dorsiflex the foot and bring the toes up on the ground so we can achieve proper swing through and a more normalized gait pattern. So it's one thing you're thinking about, but you can see them all, right? There's a fancy one. She just looks real happy to be hanging out on her bike. And that's a real world commercial example of what we just saw in the last slide. So kind of cool. You'll see these mostly for lower extremity stimulation a lot of the time. There's like an EMG triggered NMES. You can use these for various things like antagonist contraction to reduce agonist spasticity. So one thing, if I'm like really spastic in my bicep, one thing I can try and do is fire the tricep as the antagonist to get the bicep to relax, right? Then you can also agonist contraction. So if I just need strengthening of that bicep, I can stimulate that bicep to increase strength and muscular control. Spinal cord, again, you're trying to fight against typically muscle atrophy. You can help to improve circulation based on the parameters you use. You can contract a muscle to assist with locomotion like we do with our functional stim. And you can also sort of try and contract muscles for functional activities like hand grasping, sometimes respiration, voiding of your bladder or bowel. But it's hard because you have to have, especially now we've affected the ability of that nerve to work because of the injury to the spinal cord. So I need to introduce a high level pulse duration and a high level pulse intensity just to get what I'm looking for. And you're also trying to make sure that's not painful. So edema control and improved circulation, acute edema. So you've got trauma to the blood vessels, right? That's what in terms of you have trauma to the blood vessels, blood leaks out into the interstitial space, blood and plasma, and that's what a bruising is. That's what your edema is, right? So most of these components are negatively charged. So when they encounter another negatively charged influence, like in our Ionto or some kind of polar setup, like a high vault, when using the example of those, right, putting those two magnets together like we did in class, the positive and negative attract, but if I flip one around and now I have a positive and positive, or in this example, a negative and negative, I'm actually going to create resistance. So in order to affect edema within the body, that's what we do, is we try and most of the tissue, most of those blood, that lymphedema, blood cells, plasma that floats into the interstitial space is going to be negatively charged. So if I introduce a negatively charged ionic electrical stimulus on the outside, I fire that up and it will start to repel those other negatively charged blood plasma, things like this, and push it from the area. And that's how we affect and impact edema control, and that's how we improve our circulation. So we're shifting the excess fluid away from where we don't want it, right? You can also get a muscle pump facilitated by muscle contraction. So we can ask the muscle to contract, and that can help to push lymphedema, edema in general, and improve circulation just overall from a place that it's not useful to a place where it could be reabsorbed. Yep, know these, right? This is from the other one. Contraindications, precautions. Understanding how to the application of this, just the setup, how to select the device. We'll get more into this. Electrode placement, right? So for NMES, we got to have at least one electrode over a motor point, and then you have to have typically the other electrode, depending on your setup, aligned parallel to the muscle fiber and direction for the best quality contraction. And those two electrodes needs to be at least, they say 2 inches, but at least one electrode space apart, which most of your electrodes are 2 inches in diameter anyways. Trying to keep the joint in the mid-range, right? So we want it to be in that happy place. Oh man, we remember the action potential, like the muscular contraction curve, right? So it can't be too far towards passive length tension, can't be too far towards active length tension, needs to be in that happy place right in between, right? And that's going to prime. Again, that's where actin and myosin are happiest, right? That's where they're most primed. They're at the optimal length to be able to fire more accurately, more actively. So we want to put it in that optimal length area when we're doing our stimulation, because it better advantages the muscle to be able to give you a quality contraction. That should make sense. And these are our just parameters that we're going to manipulate: amplitude, pulse duration, frequency, and on and off time. All right, know these charts for sure. Know these charts. Yeah, I've got your little cheat sheet, but look at this one for sure. This is going to give you everything you need to know in terms of delivering the parameters for NMES based on what your goal for this is. So know these 100%. That's going to be on your quiz, no doubt. Innervated and weakened muscles. So here's just a rundown of this in terms of what waveform is best. The intensity, right? The intensity is going to be as tolerated. I'm going to take them. Obviously, I want to get to a muscular contraction, but I don't want to turn it up so high that they're like in agony the whole time. This gives you parameters for the duration, frequency, the ramp up, ramp down time, on and off times, right? So there's like a 5-to-1 setup, and then your rests in between, right? So All of that you guys should know. Here's max overload. So the parameters for strengthening innervation muscle, max overload is desired. And the one thing that you'll see is you're changing on and off time, not too much in terms of the intensity being as high as you can tolerate. So it's basically a max contraction, 60% of your max contraction. Max voluntary isometric contraction is what MVIC stands for. Good. Just know these guys. Put these in your head. Look into your camera, and it's all in there. Look at your book. Functional electrical stim, there it is right there. Same deal. Knowing the principle of fatigability for muscle spasm, right? So if a muscle's constantly already contracted, I'm going to try and overload that muscle, fatigue it, so my on-off times are going to change. Might be let's just say like a 1-to-1, where it's 5 seconds on, 5 seconds off, 2-to-1, 5 seconds on, 10 seconds off. But I'm going to increase the amount of time that muscle is firing or being asked to fire, so I can wear it out and I can fight against any kind of spasticity. There you go. There's muscle spasm right there. And that's what we see it reflected in our on-off times, right? 2 to 5 seconds on, 2 to 5 seconds off is of equal ratio. And that's to increase the fatigability. NMES, and swelling. So you're trying to stimulate normal muscle contractions that will devise a muscle pump that will help to push swelling out of the area. Here it is right here. There's no good evidence that it says it decreases effusion or swelling. So just understanding how we say it's supposed to work, but don't give it too much credence because the efficacy for this is not necessarily there. The idea is that we can contract the limb and compress when we have a muscular firing. It compresses, puts pressure on the veins and the lymphatic vessels, and that pressure on and off will help to pump and push any stagnant fluid or stagnant blood or whatever it might be, that edema, that resting edema, push it out from places where it's sort of pooling because you have poor peripheral circulation or lack of motion, whatever, and pushes it into a place where it can maybe be reabsorbed by the lymphatic system or by the vascular system. Obviously, you don't want to do this again, like with what we're going to learn in compression, for someone that has edema caused by organ failure, like congestive heart failure, right? If the edema is being caused by an inefficiency of an organ structure to be able to move that edema, the last thing we want to do is pressure that organ structure more by pushing that edema back into a place where it's already disadvantaged. You can really, obviously, that can be bad news for your patient. So that is certainly a contraindication. There's your edema reduction. This has a great chart in Cameron. Look at that chart and just start to learn these parameters by heart in terms of what am I going to put my pulse frequency at? What am I going to put my duration at? How am I adjusting my on and off times? How am I playing with these parameters to get different responses to my neuromuscular stim? Denervated muscle, there you go. We love these PowerPoints, right? Questionable, controversial, right? Are we able to derive enough electrical impulse to be able to get any positive benefit or deliver any positive benefit to a nerve that no longer knows specifically how to work, or it's whose communication system has been impacted some way negatively because of some degenerative problem or trauma or something like this? So again, it probably doesn't hurt to try, but they're likely, if you're going to go and use this with certain patient populations, there's going to be a limitation to how long you can do this without being able to notate any success. So again, efficacy is not necessarily there, but this is where your documentation is so important, right? If you're doing this and you're doing it with a patient and you're saying, based on my MMT findings or the range of motion, or I'm taking this patient from no contraction to a trace contraction, and you can demonstrate that this is working, you might be able to validate reimbursement and continuation of this treatment. But obviously, if you're trying it and you're not getting anything, don't give this to a patient for 50 visits and just say, oh, well, it seemed like it was working at the time. We have to do what's best for our patient. So there's your EMS sort of parameters, guidelines for what you would do. DC, again, probably best because it has that long duration monophasic or biphasic setup, right? So we need a lot of energy over a long period of time if we're even going to think about trying to activate a denervated nerve. What you'll see in the clinic, like we saw already in our labs, you've got these large machines that can give you stimulation that they just plug into the wall, um, like we've used, and then you've got portable ones now. Brian brought in his portable neuromuscular stimulator. Outside of that one, we only have TENS units, but they're pretty convenient, right? Because you can move them around. At the clinic, we pretty much just use portable units because, for the most part, I can get enough juice out of them to be able to get a strong contraction, and it's easier for me to just place it with the patient. But outside of that, sometimes I might need a little bit more, so I need to plug into a wall unit. So that's the other side of this. So there's your muscle stim, guys. Big things to know for the quiz are going to be your parameters, right? How are you going to adjust parameters for different things? What are your contraindications? What are your indications, contraindications, precautions? What are the potential adverse side effects? How are you going to do your setup, right, in terms of electrode placement, spacing, those sorts of things? Nothing super crazy with the wavelengths, but definitely know like the differential between your biphasic and how those are sort of reflected in the type of stim that you're providing. Outside of that, for neuromuscular stimulation, it may be like a case scenario. That's something you're going to have to look into in terms of your practical, right? How am I going to, like we practiced before, oh my gosh, I'm seeing an MMT of 3 out of 5. This patient doesn't have any contraindications. I would probably want to use neuromuscular electrical stimulation to try and increase the strengthening of that quad or that muscle belly from a 3 out of 5 to a 4 out of 5 to improve function. So knowing things like that for your NMES are going to be great. Like I said before, understanding that action potential curve that we had on the previous slide, that's going to be important to know. Knowing the differences between pulse rate, pulse width, and frequency, that's going to be important to know. Being able to define those things and understanding that it's the combination and how we sort of vary or tweak those parameters that defines exactly what the outcome of our stim is going to be. Like, what are the different pulses per second or frequencies or pulse durations for, let's just say, in neuromuscular for muscle re-education compared to muscle strengthening, or for a deinnervated muscle, or for to produce a muscular pump to assist in edema. So knowing those things are going to be important for your quiz. Definitely put that on your list of study stuff. And I've got one more for you guys. We'll go over pain control, and that should hopefully have you all in a good place for next week's quiz. So I will see you on the next lecture.